On behalf of the NAP Executive Committee, I want to welcome everybody to the 2021 spring meeting of the Nebraska Association of Pathologists. We're very excited for today's presentation. I'm actually, our guest, Dr. Andrew Bellizzi, came very highly recommended by multiple folks, and I'm sure we're all going to learn a lot. As I kind of mentioned in my message in our newsletter here a few weeks ago, these meetings are important touch points, and I'm very glad we're still able to have them. I know that initially we were kind of unsure about doing things in a virtual format, but we are all Zoom experts now. In fact, just the other day, we were actually sitting in a physical meeting in a room here with people without masks on. It was bizarre. It was really surreal to actually not be able to do work while the meeting was going on. I think we're ready to get back to that most definitely. As I mentioned numerous times in the communications that I've had, both via email, the newsletter, et cetera, and at the fall meeting, our main goals for the last year that the exec committee identified for the NAP were twofold. One, to increase communication, and to two, highlight our advocacy efforts. And I think that we've been able to do meet the first goal more so than I would have believed at the beginning, with things like the newsletter, the numerous communications that you folks have all received, not only from Carmen and the team at the NMA, but also from exec, et cetera, as well as things that we forward on from the CAP. So I think we're doing a much better job communicating with all of you and letting you know what's going on both on the advocacy front and just what exec committee is doing, how your membership is working for you. Second part of that, which I've kind of already alluded to, is the advocacy efforts, and Carmen and the NMA team are going to be speaking a lot more about some of the many things that have been going on with that. And it just shows again how membership in the NAP, as well as the partnering that we do with both the CAP and the NMA, is critical to not only helping us in our practice, but also helping us care for patients and continuing to do so in the most effective and cost-effective manner. A couple things before we get rolling. Some thanks have to be issued first off to our sponsors, our two gold sponsors, which are Alexion and Caris, who you're going to hear from a little bit later in the talk today, and our silver level sponsor, AstraZeneca. It's their support that lets us put on these types of meetings, so please give them their attention when they talk. And on the virtual meeting platform, there's an area for the exhibitor area. Please go check those out. Again, we really appreciate their support and welcome them to the meeting. And we also have to thank, again, Carmen and the staff at the NMA for helping to put together this meeting and get everything rolling. And so, again, on behalf of exec and the NAP, thank you very much for the work that you folks have done. We're going to talk a little bit about the fall meeting in the business portion of the meeting here at the very, very end. But a couple of updates I want to get out of the way, a couple things to watch for, I guess, before the fall meeting, just so I don't forget it, and if people fall off before we get to the business meeting. First off, many of you may have seen, if you're in the Omaha area, there's going to be the Herbeck Hustle Memorial 5K that'll be happening at Lake Zorinsky, and we will, in the chat here, I'll put the link to that if you folks are interested in registering for that. Again, this is honoring the man that many of knew very, very well, Dr. Herbeck, was so active in the CAP, as well as other medical organizations around town in the state, and the NAP is one of the former presidents. The benefit, all of the proceeds from that are going to not only see, test, and treat with the CAP, but also the Dr. Jerry Schenken and Jean Herbeck MLS Student Program Fund. So it's for a very, very good cause. The other thing to watch out for is coming up this fall, we are going to be resuscitating our Advocacy Journal Club, in which it's mostly for residents, but everybody's welcome to participate. More details to come on that. Again, that will probably happen, the first of those will happen again during the fall. So without any further ado, I'm going to go ahead and turn it over to the next part of the program, to the first of our gold sponsors, who I believe is Caris. Is that correct? Very good. All right, as I mentioned, please feel free to take a peek at the exhibitor booth, which probably has more information there, and also there's a chat function there if you wish to ask questions of that method, that route as well. So please consider heading that direction. Without further ado, it is my pleasure to introduce our invited speaker today, Dr. Andrew Bellizzi. Dr. Bellizzi is a clinical professor in the Department of Pathology at the University of Iowa. He completed his undergraduate work in anthropology and science pre-professional studies at the University of Notre Dame and received his medical degree from Northwestern University. Following combined training in anatomic and clinical pathology at the University of Virginia, he completed a fellowship in gastrointestinal and liver pathology at The Ohio State University. After 2 years as junior faculty at Brigham and Women's Hospital, he moved to Iowa, back to a good area of the country, in the fall of 2011. Dr. Bellizzi is the director of immunohistochemistry, GI pathology, and the GI Pathology Fellowship at the University of Iowa. He's an active member of the United States and Canadian Academy of Pathology, the American Society of Clinical Pathology, and the College of American Pathologists, including serving as chair of the USCAP Stowell Orbison Award and the CAP Immunohistochemistry Committees. He is Secretary-Treasurer of the International Society for Immunohistochemistry and Molecular Morphology and is an Associate and Assistant Editor of Applied Immunohistochemistry and Molecular Morphology and the American Journal of Clinical Pathology, respectively. Dr. Bellizzi's research interests include the diagnosis, classification, and etiopathogenesis of human disease, with an emphasis on gastrointestinal, pancreatic, neuroendocrine, and hereditary tumors. His research program focuses on the applications of diagnostic immunohistochemistry. Outside of the office, despite all the stuff that he does, he enjoys getting into trouble with his 12 and 14-year-old boys, Aiden and Darby. In addition to very special stains, he also likes hiking, cooking, craft beer, Notre Dame football, the Red Sox, and the Oxford comma. So without further ado, Dr. Bellizzi, on behalf of the NAP, thank you for agreeing to come speak to us, and I turn the floor to you.
Thanks, Jeff. Sorry for the mouthful. How is the sound? You let me know. I got a new mic, and I haven't had a chance to test it out. If there's any trouble, we could use the mic off of the webcam.
Sounds perfect.
Great. Just gonna share my screen.
Go Hawks.
Go Hawks, yeah. Do you see the presentation in the full screen, or are you seeing the cropped out one?
We've got presenter view.
Yeah. How about now? We're good? All right.
Good.
Great. So we're doing algorithmic approach to define tumor type and assign set of origin in carcinoma of unknown primary. We got on a couple minutes before, and I was telling everybody that the main goal for this talk is to establish relationships with you all. I do the same thing that you do, and I learned so much from interacting with you all. If you're stumped on a case, if you want to share a hard case, if I told you something and I'm wrong, I'd love to hear about it, because I've been doing this for 15 years now, and I learn new stuff every day. So if you want to get a hold of me, please feel free to email me at andrew-bellizzi@uiowa.edu, and I'm also on Twitter at IHC_guy. I don't have anything to disclose, unfortunately. These are really the take-homes from the talk, and all this stuff seems trite, but when you bump into a case and you don't immediately know what it is, that's really, really uncommon. I'd say 99.5% of the time you put this slide down and you know what it is instantly without thinking about it. I call that subcortical diagnostics. But when you have to engage your brain, what I refer to as cortical diagnostics, all common sense flies out the window. So when you feel things slipping away, take a big deep breath and consider formally, what's the age of the patient? Are they a man or a woman? And where are we? Always consider primary versus metastasis. We have this inclination again when we are out of sorts because we don't know what it is, to immediately jump to metastasis, and we fail to consider the primary tumor that's native to the tissue in which the biopsy is derived. So for example, in a liver biopsy, a very frequent one is failure to consider primary intrahepatic cholangiocarcinoma. Turns out, actually, most metastasis of occult origin, or at least very many, are in fact intrahepatic cholangiocarcinoma. There are screening markers and there are differentiation markers. The screening markers are few. Broad spectrum epithelial markers like a pan-keratin, and we'll talk more about pan-keratin in just a bit. CD45 for hematolymphoid, SOX10 for melanoma, SAL4 for germ cell tumor. Beyond those few, everything else is a differentiation marker. And probably the most important thing that I can share with you tonight is don't start ordering differentiation markers if you're unsure about the broad tumor class. I've got a case on my desk that I was looking at right before I hopped on the line, crushed small biopsy from the esophagus, and pathologist ordered a bunch of lymphoma diagnostic markers, and it's a poorly differentiated carcinoma. Just if you don't know what it is, you're only allowed to order keratin LCA and SOX10 or S100. A few other things: don't be a hero. Use work aids. So I started giving this talk because I couldn't figure out a lot of cases. When I started out, I couldn't figure out very many cases at all. And every time I had a question, I researched it and I made it into a PowerPoint slide or a set of PowerPoint slides. So these are the work aids that I use in my practice. It's always a good idea to show a colleague. We each have our mental blocks from day to day, and the case that's really inscrutable to you might be really obvious to one of your buddies, and then the next day they'll have one and they're stuck, and you'll know what the answer is right away. Here's another really important take home from the talk: don't be penny wise and pound foolish. This is how we took care of liver biopsies until very recently. We'd get multiple liver biopsy cores and we'd throw them all in one block. And the sentinel event was it was a medical liver biopsy, but it could have just as well been a tumor biopsy. And it was overnight. The overnight histotech rushed and probably tired and frazzled, faced through the block. And so we've got this patient who's undergone a procedure and we've got literally nothing to show for it. And we were being penny wise because we just want to embed as few blocks as possible, cut as few slides as possible. But after that sentinel event, we started dividing our liver core biopsies, both medical and for tumor, into multiple blocks. And I'd recommend this for any oncology specimen. And this is right up, I see Matt shaking his head because this is right up Matt's alley. Every cancer biopsy in this day and age is a potential molecular oncology specimen. A few years ago, it was non-small cell lung cancers were getting EGFR testing, but it's really, really taken off from there. Now we're doing extensive NGS panels on many other tumor types. Most recently, we started doing it in cholangiocarcinoma. So you got to divide the sample. You want to have one block for your immunohistochemistry workup, another block I designate right up front for molecular testing. Another thing is if you order IHC, always have a plan for a second panel or a third panel. If you order Keratin LCA S100 because you don't know what the tumor is, you'll have to think ahead and say, well, if the keratin turns out positive, this is going to be my next panel. Or in that same tumor, if the S100 or SOX10 come back positive, this is going to be my next panel. If the LCA comes back positive, this is going to be my next panel. Think about what that next panel might be and cut up front for what that next panel might be. Everything that I'm discussing today, if you're interested in narrative format, is in a review article that I published in Advances in Anatomic Pathology last year. If you guys, I'm not sure, I'm happy to have these slides posted on the Nebraska Association of Pathologists website. I'm happy to send these slides to anybody, or anything that anybody wants, just hit me up. But this article is an extensive, it's a long read, but it's worth it. I generate a ton of data. I've been building tissue microarrays for as long as I've been at Iowa, for 10 years now. So the data that I'm gonna present to you is based on my individual experience, data that I've generated in my own lab, and the results, the central mass of the aggregated published literature. So I'm a compulsive aggregator of the published literature. But that being said, immunohistochemistry results are assay dependent, and the same analyte analyzed in different labs, different immunohistochemical assays are not necessarily equivalent. So, results that I might get in my lab, or what the median lab might get, might not reflect the findings in your lab. So that being said, I encourage all of you to take an active role in your immunohistochemistry lab. I want as many of you guys on the line to be immunohistochemistry lab directors or associate directors, or at least be immunocurious, know what clone you're running, and know what assay conditions you're running, know what autostainers you have in your lab, because all of those things would potentially impact your results. Specific topics for discussion: the concept of next generation immunohistochemistry, broad tumor classes with associated screening markers, non-canonical expression of broad tumor class markers, that's a pitfalls section, added value of semi-quantitative IHC stain assessment, core IHC algorithms, the concept that everything dedifferentiates, and then there's some bonus material that I likely won't get to, but lists of stains that I hate, that I'm especially unfond of, and stains that I love, which tend to be oligospecific transcription factors. And then actually at the end, a table of diagnoses to consider before striking out on what I call a triple negative malignant neoplasm. And what I mean by triple negative malignant neoplasm is a keratin LCA S100 negative tumor. So next generation immunohistochemistry, this is my bag. It's a field in which we take advantage of discoveries in the developmental biology and the molecular genetic literature to identify markers through gene expression profiling and protein correlates of molecular genetic events. Markers identified by gene expression profiling are often lineage restricted transcription factors, and these are the best contemporary markers. On the right, there's some examples. So here's gene expression profiling data. This is a figure from the paper in which GATA3 was first identified as a marker of urothelial carcinoma, published in AMJ Surge Path about 15 years ago. Discovery is exciting, and these discoveries can so rapidly be adapted to clinical practice. So through whole exome sequencing, NAB2 STAT6 was identified as the oncogenic driver of solitary fibrous tumor. This was a tumor type for which we had no specific immunohistochemistry marker. We had CD34, which was sensitive but expressed in lots of things. We make this discovery, and within a few months, STAT6 immunohistochemistry is published as a essentially perfect marker of solitary fibrous tumor. And a lot of these next generation IHC markers are perfect or near perfect. Example in the lower right-hand corner was a youngish woman with an axillary mass. All the tumors that I show you, they all look the same. They're all undifferentiated malignant neoplasms. And this was a triple negative malignant neoplasm, a keratin LCA S100 triple negative malignant neoplasm. Here's SOX10, diffusely strongly positive, supporting the diagnosis of melanoma in this case. So historically, our diagnostic armamentarium was geared toward cytoplasmic or membranous differentiation markers that were empirically discovered. Unfortunately, these markers tend to have reduced sensitivity in poorly differentiated tumors. So here's an example of a breast cancer, and this is about as good as mammoglobin or gross cystic disease fluid protein 15 immunohistochemistry ever looks. Gross cystic disease fluid protein, stain I hate. Gross cystic disease fluid protein 15 is gross. And here's the GATA3 in that same tumor. Transcription factors tend to be highly expressed independent of differentiation status. And I refer to this as the primacy of lineage restricted transcription factors. I like to make up turns of phrase. On to diagnosis of broad tumor class. So we're going to talk about the big four plus three more. And here we have a carcinoma, a sarcoma, a lymphoma, and a melanoma from the cover of Baby to May. First thing I do when a tumor crosses my microscope and I don't immediately know what it is I try to put it in a bucket or one or more morphologic buckets, and I'm trying to decide, is this a spindle cell tumor? Is this a round cell tumor? Is this an epithelioid tumor? Or is this anaplastic? And that informs the differential. And for each of these patterns, we've got principal diagnostic considerations and an initial screening panel. For the epithelioids, it's a broad spectrum keratin, CD45 and SOX10 for me. The panel that I'd start with in a spindle cell tumor is a little different. I might dump the LCA and swap in, especially in the head and neck or lung, a P40 for squamous differentiation, SMSA and Desmond. And the round cell differential has the most idiosyncratic initial screening panel because you've got all those round cell sarcomas to contend with. Another consideration is, and I find this to be especially useful in generating a differential diagnosis, is the tumor monomorphous or pleomorphic. And so on the left, we've got monomorphous tumor, all the tumor cells about the same size, about the same shape, nuclei of similar quality. And on the right, we've got a tumor that's more pleomorphic. And this is a clear cell sarcoma and a melanoma. They have the same immunophenotype. They differ based on this single characteristic, monomorphism versus pleomorphism. It turns out, as I'm sure you're all familiar with, that these monomorphous tumors, a lot of them have a oncogenic driver that's a fusion and tend to be genetically simple. And things that are genetically simple are more likely to be monomorphous, and things that are aneuploid are more likely to be pleomorphic. So this is how I apply that distinction, monomorphic versus pleomorphic, to differential diagnosis for a given phenotype or at a given anatomic location. There tends to be these sort of good and evil twins, or there's a monomorphous example and a pleomorphic example in the differential diagnosis. So analogous to this clear cell sarcoma versus melanoma, Burkitt lymphoma is the monomorphous pair to a DLBCL. Mesotheliomas tend to be relatively monomorphous, and you can use that in the differential diagnosis with adenocarcinoma. Serous cancer and pancreas cancer tend to be especially pleomorphic. Prostate cancers are monomorphous, whereas urothelial carcinomas are pleomorphic, etc. So this is the first of what I affectionately refer to as wall hangers. These are the most useful work aids, and I call them wall hangers because they're literally posted to my wall. This slide, you've got this table includes the broad tumor classes, the big four plus three more. I'll reveal the three more in a moment. The initial screening markers that are useful for that diagnosis, when to consider the broad tumor class in terms of morphology or anatomic location or results of initial immunohistochemistry. And for everything but carcinoma, because this talk is focused on carcinoma, additional useful differentiation markers, confirmatory markers, diagnostic markers. So we've got carcinoma, sarcoma, lymphoma, melanoma, again, broad spectrum keratin for carcinoma, but other broad spectrum epithelial markers it's useful to have in your test menu. CD45 for lymphoma, SOX10 for melanoma. There's no broad screening marker for sarcoma. Vimentin is inappropriately applied as such, and Vimentin is very broadly expressed. It's ubiquitously expressed by melanomas. Many hematolymphoid tumors are Vimentin positive. If your differential is carcinoma versus sarcomatoid sarcoma versus sarcomatoid carcinoma, and it's carcinoma, your Vimentin is bound to be positive. So Vimentin, just don't. Stain I hate the most. How about the three more? Don't forget germ cell tumor. If you don't consider germ cell tumor, you're bound to miss it. Germ cell tumors are broad spectrum epithelial marker positive, with the exception of seminomas that tend to be pankeratin weak to negative. So if you don't consider germ cell tumor, your pankeratin only tumor is apt to be one. When would you especially consider a germ cell tumor? In the gonads, of course, but really anywhere in the midline, the mediastinum, in the brain, in the midline. Mesothelioma, just like carcinoma, if you don't consider mesothelioma, especially in the pleura and the peritoneum, your pankeratin only positive tumor is going to be a mesothelioma. And then paraganglioma, pheochromocytoma are in the differential diagnosis with neuroendocrine tumor. Some especially useful confirmatory markers. I have this panel that I apply in CD45 weak to negative lymphomas. So I'm very paranoid about duffing a anaplastic large cell lymphoma, plasmablastic lymphoma. I'll show you a slide of this in a few. For melanoma, we've got SOX10 or S100 as the screening marker. I prefer SOX10. It's more robust. The only exception I'd say is watch out in a decalcified specimen in which transcription factors in general tend to be a little bit less robust. So you might have an S100 positive SOX10 negative melanoma in a decalcified bone marrow, for example. Differentiation markers, melon A, HMB45. Sarcoma, some especially tend to be missed sarcomas, dedifferentiated liposarcoma. So you've got a nasty tumor in the retroperitoneum, a 20 centimeter tumor, a 40 centimeter tumor, considered dedifferentiated liposarcoma, and that's MDM2 and CDK4 by IHC or MDM2 by FISH. Dedifferentiated liposarcoma can look like anything, so it doesn't just have to be spindle cell pattern. They could be epithelioid or round cell, anaplastic, or a combination of patterns. Angiosarcomas, especially epithelioid angiosarcomas, tend to be keratin positive. So epithelioid angiosarc is a tumor that's mistaken for metastatic carcinoma, and you just, it's one that will defy typing because it'll be negative for all the transcription factors that you would normally apply in carcinoma. So consider the possibility of epithelioid angiosarcoma. Another one is epithelioid sarcoma, the SMARCB1, INI1 deficient tumors that tend to occur in association with tendons and aponeuroses. So INI1 for epithelioid sarcoma. When I'm really up against the wall, CD34 positivity is not uncommon in poorly differentiated sarcomas, and it's exceptional in carcinoma. So if I have an undifferentiated malignant neoplasm that's negative for everything, but it's got some CD34 in the absence of other vascular differentiation markers, I might say undifferentiated malignant neoplasm favors sarcoma. For germ cell tumor, we've got OCT4 for seminoma, along with KIT and D240. In embryonal carcinoma, OCT4, CD30 and SOX10. For yolk sac tumor, AFP and glypican-3. For trophoblastic tumors, beta-HCG, although a very problematic, troublesome stain, very difficult to optimize, GATA3 in trophoblastic tumors, inhibin A, and actually PDL1 is strongly positive in choriocarcinoma and placental site trophoblastic tumor, epithelioid trophoblastic tumor, et cetera. Mesothelioma, calretinin, WT1, of course, D240, and D240 is the best marker for sarcomatoid mesothelioma. Those are often just keratin positive only. Calretinin and WT1 only 25 to 33% sensitive in sarcomatoid mesothelioma. CK5-6, BAP1 loss. And then parapheo, GATA3, FOX2B if you have it. So now we've gotten to carcinoma. And how do we get to carcinoma? We've got something that's cohesive and expresses a broad spectrum epithelial marker. And I think of carcinoma in terms of 4 boxes. So now, I mean, this was an hour ago and my neuropathology colleague was showing me a brain met. And I run through this algorithm in my head for every carcinoma of unknown type or origin. And she showed me a high grade, solid, nested thing. And the differential that I go through is this what I call garden variety adenocarcinoma? So that's something that I readily recognize as adenocarcinoma. It's making glands, tubules, papillae, there's mucin. What I refer to as large polygonal cell adenocarcinoma, those tend to either be nested or occur in sheets, centrally placed nuclei. Squamotransitional carcinoma, so that's squamous cell carcinoma and urothelial carcinoma, and then neuroendocrine tumor and carcinoma. For garden variety adenocarcinoma, I'll go through immunohistochemical algorithms for those, and that's a big take home for this talk. Uh, a hint, a clue, a tip for the large polygonal cell adenocarcinomas, and that's HCC, RCC, and adrenal cortical carcinoma. Those tend to be CK7 and CK20 double negative. I might use one or more of these to support a diagnosis of hepatocellular carcinoma, HepPAR1, Glypican-3, Arginase-1. For PAX8, I'm sorry, for RCC, all you need is PAX8, most sensitive renal cell carcinoma marker, all that I would use to support a diagnosis of renal cell carcinoma. For adrenal cortical carcinoma, there's a clear best first line or best diagnostic marker. It's SF1, steroidogenic factor 1. Lots of folks don't have it. SF1 is 95% sensitive. Melon A is about 80% sensitive. Everything else is less sensitive. Inhibin, A, calretinin are about 60% sensitive. Synaptophysin is 60% sensitive. I used to use it to support a diagnosis of adrenal cortical carcinoma. At least as often I encounter it as a pitfall. So an adrenal cortical carcinoma, that's not surprisingly, synaptophysin is mistaken for a neuroendocrine tumor or is mistaken for a parapheo. Squamotransitional, P40 is the most sensitive marker for squamous cell carcinoma and urothelial carcinoma, in excess of 95% sensitive, varies from organ to organ. For lung squam, though, for example, it's in excess of 99% sensitive. 34 beta E12, so high molecular weight keratin, similarly sensitive to P40, but much less specific. Lots of adenocarcinomas will have some high molecular weight keratin. GATA3, variable. Urothelial cancers, 80% of urothelial cancers are GATA3 positive. Tends to be strong. Squamous cell cancers, you can have some GATA3 and it tends to be much weaker, and it occurs at specific anatomic locations, cutaneous ones, and ones that arise in the anogenitourinary tract. And then neuroendocrine, chromogranin and synaptophysin are our general neuroendocrine markers. I'm quite fond of INSM1, specifically in PDNEC, poorly differentiated neuroendocrine carcinoma, small cell cancer, and large cell neuroendocrine cancer. I have found that INSM1 is more sensitive than chromo and synapto in poorly differentiated neuroendocrine carcinoma. Very frequent question, which screening keratin should I use? And the answer is at least one, and there's lots of good choices. I use keratin AE1, AE3 almost exclusively. I use keratin AE1, AE3, and EMA and monoclonal antibodies to EpCAM, epithelial cell adhesion molecule. Those are MOC31 and BERT-EP4. We also have a pan keratin in our lab, which is a cocktail of AE1, AE3, and CK7 and CK8 and 18. And that's something that I inherited when I took over the lab. Different broad spectrum keratins react with different keratin subtypes, but it's not the number of keratins that your pan keratin reacts with that is as important as the sensitivity and sensitivity, I should say, the affinity that the clone has for those individual keratins. As you know, stratified epithelia express high molecular weight keratins, and that's keratin 1 through 6 and 9 through 17. And simple epithelia and adenocarcinoma express the low molecular weight keratins, and those are CK7, 8, 18, 19, and 20. This is super important, and it comes up every week, literally multiple times. It doesn't matter how many keratins your pan-keratin reacts with if it isn't well optimized. And this harkens back to my entreaty that you guys engage in your individual immunohistochemistry laboratories. These are results from the Canadian immunohistochemistry proficiency testing program. We've got on the top, this is AE1, AE3 in one lab. This is a liver, and this is a kidney. And on the bottom, AE1, AE3 from another lab. This in D here, this is a liver, and E is a kidney. And so your lab's broad spectrum keratin should react with cholangiocytes like gangbusters, but it should also react with hepatocytes at least moderately. And your lab's pan-keratin should react with the distal nephron like gangbusters, but should at least be moderately reactive for proximal tubules. And lots of labs pan-keratins do not. And that's what I see every week is cases where the pathologist is stumped because it should be carcinoma. But the broad spectrum epithelial marker, the pan-keratin's negative, and it leads to diagnostic confusion. And it's on the slide. Someone's sending me a liver tumor, probably a liver met, and the liver, if the hepatocytes are negative. So guess what? If your pan-keratin doesn't react with hepatocytes, it's not going to react with hepatocellular carcinoma. If your pan-keratin doesn't react with the proximal nephron, it's not going to react with the kidney tumors that recapitulate the proximal nephron, namely clear cell renal cell carcinoma and papillary renal cell carcinoma, you know, the renal cell carcinomas that we actually see. So this is something to pay attention to. And if your pan-keratin looks like D and E, act. And if you have questions as to how to act, reach out to me, and I'm happy to help you re-optimize your broad spectrum epithelial marker. Let's flex to pitfalls. Here's a case I saw several years ago. It was an 80-year-old that was presenting with neurologic symptoms, and they had a large cortical mass, brain mass, another epithelioid malignant neoplasm. And great pathologist, Gary Baumbach, he's retired now. He's the neuropathologist. The trainee on the case was Erica Savage. She's a GI pathology faculty at Cleveland Clinic now. Very smart. They did the right stuff. They thought epithelioid malignant neoplasm, cohesive. They said carcinoma or melanoma, and they did a pan-keratin and an S100. And they were both positive. And they said, what kind of S100 positive carcinoma is this? Very smart. Erica, very smart, knew that carcinomas could be S100 positive, including breast cancers, salivary gland cancers, cutaneous tumors, adnexal tumors especially, but almost any carcinoma could be S100 positive. And this is how I work this case up. Here's the MELAN-A and HMB45. So these are the melanoma differentiation markers. I also did a microphthalmia transcription factor. And this is the melanoma kind of S100 positive carcinoma. So take home point, when two broad tumor class, in this case, keratin and S100, screening markers are at odds, but more generally, when markers for both of the entities in your differential diagnosis are simultaneously expressed, you have to further adjudicate the differential diagnosis. But a clue is that the more strongly expressed marker often is the clue to the diagnosis. So S100 positive carcinomas don't tend to be so gangbusters for S100. This is a really overwhelmingly positive S100. And this is, we're getting to non-canonical expression of broad tumor class markers. Here's another pitfall. This was a big tumor up the nose. Another epithelioid malignant neoplasm or large cell malignant neoplasm. Former trainee said, I think it's melanoma, but the keratin and the S100 and Melon A that I did, they're all negative. What can you make of this? So again, all the tumors I show you, they're all going to look the same. And I repeated the pankeratin. I did a CD45, which looks like it's reacting with some scattered lymphocytes and an S100. So here we've got a triple negative malignant neoplasm. This is EMA, and my fellow, he was very smart, John, became a surgical and molecular pathologist in Kansas City, said, I think this is a SMARC-B1 INI1 deficient sinonasal carcinoma, but it wasn't that. This is the EMA. And when I saw that EMA, I said, oh, I missed it on the morphology. It was there in retrospect. Here's the CD138, the MUM1, a kappa and a lambda, and this is an anaplastic plasma cell neoplasm. And so one of my mantras is EMA positive only, beware. Sometimes your poorly to undifferentiated carcinoma only expresses EMA. Like you really, really struggle to get it to react with one of your broad spectrum keratins. But there's a suite of EMA positive hematolymphoid neoplasms, including plasma cell neoplasm, plasmablastic lymphoma, and ALCL, that overlaps with the LCA weak to negative hematolymphoid neoplasms. So this is a pitfall, and this is a useful work aid. And this is why several slides back, I had showed you I have this sort of CD43, ALK, CD30 mini panel that I apply in suspected CD45 negative hematolymphoid tumors. Here's another wall hanger. This is where I bring together what I refer to as non-canonical expression of broad tumor class screening markers. So that's keratin and EMA positive in sarcoma, lymphoma, and melanoma, and S100 or SOX10 positivity in carcinomas and sarcomas, and positivity for some hematolymphoid markers in carcinomas and melanomas. I'll highlight a few. I mentioned epithelioid angiosarcoma. So sarcomas with epithelioid cytomorphology, epithelioid angiosarcoma, and epithelioid sarcoma, to name a couple. But also just LMS, leiomyosarcoma. LMS is positive for keratin and EMA 40% of the time. EMA, I just showed you EMA positivity in a plasma cell neoplasm. I could have just as easily showed you an ALCL that was LCA negative and EMA positive. Melanomas can express broad spectrum epithelial markers, 8U1, 8E3, pankeratin, EMA, notably not MOC31 and BERT-EP4. I highlighted this, that germ cell tumors you expect them to be broad spectrum epithelial marker positive, with the exception of seminoma. We talked about S100 positive carcinomas. SOX10 is positive in tumors with myoepithelial differentiation. And I'd say this is a feature and not a bug. It turns out that triple negative breast cancers express myoepithelial or show myoepithelial differentiation. 60% of triple negative breast cancers are diffusely strongly SOX10 positive. And I've incorporated this into my carcinoma of unknown primary algorithm. CD45 never lies. So of all this illegitimacy, all this non-canonical expression, if it's CD45 positive, it's lymphoma. But CD138 that you all use as a marker of plasmacytic differentiation is positive in 40% of carcinomas. And I've seen that lead to incorrect diagnoses of plasma cell neoplasm. poorly to undifferentiated carcinoma, looks a little plasmacytoid, do a CD138, diffusely strongly positive. It's a plasma cell neoplasm, when in fact it was a carcinoma all along. MUM1 that we use as a post-germinal center marker. Conventional melanomas are always MUM1 positive. It's just as sensitive as S100 and SOX10. 64-year-old woman with a large lung mass invading the chest wall. Looks a little spindly, admixed with the fat. I was thinking sarcomatoid carcinoma, sarcomatoid mesothelioma, and someone showed this to me in consultation. It was P63 positive. And I'm like, okay, this is sarcomatoid lung cancer that, you know, used to be a squamous cell carcinoma. And they had done TTF and Napsin concurrently. Those were negative. They added a CK5/6, that was negative. And I said, I don't really like this. Oh yeah, I've got comment in the chat from Tim Greiner, personal hero of mine. Myeloid sarcoma, ALCL, and plasmacytomas are often CD45 negative, like the example that I showed. CD43 can save the day when CD45 is negative for all of the above. Yeah, and so that's in that panel for the CD45 weak to negative lymphomas. If I have a triple negative, you know, keratin LCA, S100, or SOX10 malignant neoplasm, we go back with more broad spectrum epithelial markers, and we go back with CD43. I use CD43 like CD45 in that diagnostic setting. So back to this tumor that I almost screwed up. So it was P63 only. And I said, you know what, let's get some broad spectrum epithelial marker positivity on this. And it was keratin, AE1, AE3, and pankeratin and EMA negative. And that really bothered me. And I said, hey, let's take a big step back and consider the broadest differential diagnosis. Do you mind doing an S100 and an LCA? And this is the LCA. This almost was the biggest mistake that I ever made in my career. It was LCA positive, the S100 was negative. CD20 MUM1 positive, CD10 BCL6 negative, Hans classifier, speak of Tim Greiner. Conclusion, DLBCL activated B cell type. This had been published, but I studied it systematically. We looked in 500 lymphomas, and P40 was never positive, and P63 was frequently positive. Thresholded at any positivity, it was positive in 45% of lymphomas. And among the strongest tumor types were DLBCL. So positivity, like I showed you in that example, is not uncommon. And it almost caused me to make really a fatal error. And after that case, I dumped P63 for diagnosis in my lab and immediately validated P40. So P40 is an antibody to one of two P63 isoforms, and it specifically reacts with the delta N, the dominant negative domain of P63. And it turns out that that's the isoform of P63 that has lineage fidelity. That's the one that's the marker of squamous and urothelial and myoepithelial differentiation. This other isoform, transactivating P63, has a tumor suppressor function, and it's fairly broadly expressed. It's expressed in 15 to 60% of adenocarcinomas, depending on how you threshold positivity. If you're more strict, it's 15%. But if you accept rare cells weak, up to 60%. in this study that introduced P40 to the diagnostic pathology community, it was by Bishop about 10 years ago. They showed in their study in lung cancer, 31% were P63 positive. Adenocarcinomas can be P40 positive, but when they're positive, the expression is very limited in extent, never more than a few cells. And I almost duffed this case, but in that same study, if I had been reading more closely, they looked at a cohort of large cell lymphomas, similar to the example that I showed you, and half of the large cell lymphomas in that study were P63 positive, and 0 were P40 positive. So P63, stain I hate, P40, stain I love. This comes up all the time. This is a consult a couple times a month. 55-year-old woman with a core biopsy of inguinal lymph node, anatomic location, remember age, gender, anatomic location. Sarcomas, other than those with epithelioid cytomorphology, don't metastasize to lymph nodes. That being said, it came in as rule out nerve sheath tumor. Here's the S100 and here's the SOX10. We get these cases all the time. Is this malignant peripheral nerve sheath tumor? If the S100 and or the SOX10 look like this, I call this blowout brown, it's not a malignant peripheral nerve sheath tumor, especially if they show spindle cell cytomorphology. This is a spindle cell melanoma. This is a malignant peripheral nerve sheath tumor. Unfortunately, this is what the S100 looks like in a malignant peripheral nerve sheath tumor. Average example, it's negative. Preferred marker to support a diagnosis of malignant peripheral nerve sheath tumor is H3K27. It's lysine 27 trimethyl, which is lost in about 60% of malignant peripheral nerve sheath tumors. Melanoma markers in conventional melanoma and variants. So we're talking about S100 and SOX10, but you have to know what to expect, not just in conventional melanoma, but also in spindle cell and desmoplastic variants. S100 and SOX10 continue to be highly sensitive in the spindle cell and desmoplastic variants, but it's sort of 50-50 whether you'll be able to get a these melanoma differentiation markers, I should say, to react in a spindle cell melanoma. And in the head and neck, in a suspected desmoplastic melanoma, it's unusual for melon A, HMB45, MIDF to react with the desmoplastic melanoma. Here's the MUM1, this non-canonical expression that I told you about, almost always positive in conventional melanoma. Added value of semi-quantitative IHC stain assessment. They're not just positive or negative. It's, it's expression and it's diffuse and strong or in the middle or rare cells weak, and that has meaning. So here's a case. I brought up a new, or I had a new Pax8 antibody in my lab, a new lot of a polyclonal at the time, and I was retitering, and here's the Pax8 in just a regular old lung cancer. And I proved it to myself. Here's the thyroglobulin, negative, TTF diffusely strongly positive, napsin A, multifocal granular cytoplasmic positivity. So this is Pax8 positivity in a lung cancer, but look at the TTF and look at the Pax8. So TTF is diffusely strongly positive, and Pax8, the staining's pretty wimpy. And so TTF wins. And this is, again, when you've got, conflicting results, the stronger marker often wins. And in particular, I would beware weak and patchy staining for transcription factors in general, but especially GATA3 and Pax8, where this quality of staining has no specificity in assigning site of origin. Here's a couple qualities of staining that may be useful to assign a site of origin or a phenotype. This is diffuse strong CDX2 staining. I call this homogeneous pattern, and this supports the lower GI origin, colon or appendix. This is an example of heterogeneous CDX2 positivity. It's anything less than diffuse and strong, and it ranges from focal to a little bit less than diffuse and strong. I call this heterogeneous, and this is the pattern that you typically see in upper GI cancers, primary mucinous ovarian cancers, and in pancreatobiliary tumors. CK20 looks just the same, homogeneous pattern, heterogeneous pattern. This was a lamin, and this was a metastatic primary mucinous ovarian cancer. Coordinate expression of CK7 and CK20. I will reiterate that the pattern that I find the most useful is CK7, CK20 double negativity, because that causes me to reconsider a broader differential, specifically HCC, RCC, adrenal cortical, prostate cancer. Famously, CK7, CK20 double negative, clue to potential prostate cancer. Squamous cell carcinoma, neuroendocrine tumor, neuroendocrine carcinoma, and germ cell tumors, specifically seminoma, which we said are just keratin negative. Yolk sac tumors are keratin and EMA positive, but yolk sac tumors are usually 7 negative. Very important algorithm, another wall hanger. This is probably the algorithm that I use the most often. Being a GI pathologist, I get all the liver core biopsies full of tumor. So core biopsy, I know it's carcinoma, and it looks like a garden variety adenocarcinoma, Makin glands. And this is what I run every time. CK7, CK20, CDX2, TTF. In a woman, got a 3 for breast cancer. These are the results, potential results, and how I interpret them and what the next step in the workup is. So if the CK20 and the CDX2 and or are homogeneous pattern, that's lower GI, I might add a SATB2 to support colon origin. I order MMR. If we get CK20, CDX2 heterogeneous, favors upper GI or pancreatobiliary, I might add SMAD4 loss, which would support pancreas cancer over a upper GI, esophagus, gastric. BAP1 loss would support a diagnosis of intrahepatic cholangiocarcinoma. I might add a HER2 if a GI, upper GI origin is suspected. TTF1 positive lung, GATA3 positive breast. If I confirmed a diagnosis of breast cancer, I'd add ERPR, HER2. These couple boxes are important because things never go according to plan. We get a lot of these, I call them CK7 only. The only thing that reacts on that initial panel is the CK7. And in that context, I might add napsin-A for lung, PAX8 for Mullerian, SOX10 for triple negative breast cancer. Remember, 60% of triple negative breast cancers are SOX10 positive. SMAD4, again, to favor pancreatobiliary. Cadherin 17 is a pan-gastrointestinal marker similar to CDX2, and it's slightly more sensitive. BAP1 again for intrahepatic cholangiocarcinoma, and then recall CK7, CK20 double negative, HCC, RCC, adrenal cortical prostate, and reconsider possibility of squamotransitional or neuroendocrine. Few examples, or talk about a few markers from that last algorithm. Why TTF1 and not napsin-A? So in the review article that I shared with you, I did a meta review of published studies of TTF and napsin-A positivity. I found the markers to be identically sensitive. When you do both, you go from 80 to 90% sensitive. I do use napsin-A mainly to support a diagnosis of clear cell carcinoma of Mullerian origin. Here's literature describing SOX10 positivity in triple negative breast cancer. This is the cadherin 17. So here's an ampullary cancer that was CK7 only. Here's the CK20 and CDX2. And here's the cadherin 17, gangbusters positive. So gives you good support for a GI origin. Aggregated some literature around cadherin 17 and CDX2, and there's a little bit of pickup in sensitivity in each of the organs for cadherin 17 relative to CDX2. I call it exception to the rule. I said primacy of lineage restricted transcription factors. And actually, this is an example where a differentiation marker beats the transcription factor. And that's because CDX2 isn't really a pan gastrointestinal marker. It's favorably expressed more distally. And actually, in terms of research interest, I recently developed and described a pan gastrointestinal marker that's more sensitive than cadherin 17, and that's called GATA4, coming to a journal near you soon. Here's an example of BAP1 loss in an intrahepatic cholangiocarcinoma, specifically the small duct type of intrahepatic cholangiocarcinoma. Looked at that throughout the biliary tree, and it has good specificity for intrahepatic origin. I've got lots and lots of similar algorithms. I see we're sort of short of time. I'll just hit a couple highlights, and I don't know if there'll be a few minutes for questions. I'll also stay on for the rest of the meeting, and I'm happy to take questions after the next few presentations. So we've got a similar algorithm for primary surface ovarian tumor versus metastasis with a very similar scaffold. Remember, it was in the liver, it was 720 CDX2 TTF, GATA3 in a woman. For this, it's 720 CDX2 and PAX8 with decision points and interpretations and further markers to order. This is a scenario where I also incorporate the clinical, the gross. Is it unilateral or bilateral, and how big is the tumor? And I've got multiple other algorithms. I have an algorithm that's sort of scaffolded on that 720 CDX2 TTF for every different anatomic site that I can think of. So I've got a mediastinal panel, and a pleural panel, a peritoneal panel, a retroperitoneal panel, and a bone panel. So for example, bone panel, 5 most common carcinomas to metastasize to bone: lung, breast, prostate, thyroid, kidney. So TTF, GATA3, NKX 3.1 in a man. Don't need anything for thyroid. We've already got TTF and PAX8 for kidney. Retroperitoneum, I told you, consider dedifferentiated liposarcoma. I said we always jump to metastasis. So in somatic soft tissue, everywhere that the biopsy is derived from, if it's derived from a lymph node, it might be a lymphoma. If it's derived from a viscera, though, it's carcinoma. But when they're derived from somatic soft tissue and they show epithelioid cytomorphology, we jump to carcinoma. But don't forget, if you're in somatic soft tissue, it's apt to be a sarcoma. Show you just a couple more things. We had talked about GATA3 in urothelial versus squamous cell carcinoma. This is a wall hanger. This is a common question, frequent sort of differential. Squamous cell carcinoma versus urothelial carcinoma. When you're about to diagnose squamous cell carcinoma, always consider urothelial carcinoma. Markers that are positive in urothelial carcinoma: CK20, 50% of the time, GATA3, 80% of the time. Squames can be positive, but it tends to be weak and patchy. Uroplakin-2, stain I'm fond of, sensitive, 70%, very specific. And I'll just show you a couple more algorithms. This is well-differentiated neuroendocrine tumor site of origin algorithm, CDX2 for midgut, PR and or polyclonal PAX8 for pancreas, TTF for lung, SATB2 for rectum. I have a much fancier algorithm, but this is a huge piece of my practice. I see 200 new neuroendocrine tumors a year. But these markers, all of you should have in your lab. Neuroendocrine carcinoma, you can distinguish cutaneous from visceral origin, and it's TTF for viscera and CK20 for skin, for Merkel cell carcinoma. I'll highlight poorly differentiated neuroendocrine carcinomas tend to express multiple transcription factors independent of site of origin, irrespective of site of origin. I call this transcription factor lineage infidelity, leads to diagnostic confusion. And I think this is the last algorithm. Algorithm to distinguish well-differentiated neuroendocrine tumor grade 3. So with Ki67 proliferation index in excess of 20% from large cell neuroendocrine carcinoma. And really the most useful stains for that adjudication are P53 and RB. I do a few others. So these are necks, and this is what P53 looks like in a neck. This is what I call missense mutation pattern, diffuse strong staining, obscuring nuclear detail. This is what I call null pattern, complete absence of staining. And then RB, you're looking for loss of RB expression. So in the lower right-hand corner here, we have complete absence of RB expression with intact internal control staining in vascular endothelium. And I think we'll cut it short there and turn it back over to Jeff, and I'll stick around for as long as there's folks to be stuck around for.
Perfect. Thank you very much. Maybe just in the interest of academic propriety, we might take time for one question if somebody has something for the group.
Stunned silence. I'm accustomed to it.
I have a question, but I don't know. It's not. Do you recommend to get INS-N1 for the neuroendocrine workup? Because I think that is a marker that we should have, because sometimes the chromogranin and the synaptophytin is negative. So adding the INS-N1 is a plus.
Yeah, if you'll indulge me I'm going to stop share. I'm going to pull up one PowerPoint slide from another talk, and I'll show you why I'm high on INS-M1. That's a great question.
Then now that you're pulling the slide, the other observation that I have, like I do cytology, so I do a lot of pleural effusion. So I try to avoid using pankeratin and keratin with the cytology. So I have been using more for the epithelial Claudin 4 and ETCAN, and not cytokeratins.
What's your and where are you? Where do you practice?
At UNMC, Nebraska Medicine.
And you're mainly cytopathology?
Yes.
And you guys have Claudin 4?
Yes.
And you like it? And
yes.
So Claudin 4, it flashed across a few of the slides. So Claudin 4 is a broad spectrum epithelial marker for you all to consider. Mm-hmm. Like it's in my development queue. Mm-hmm. There's always a long list of stains in my development queue. And I already have BMA, and I already have MOC31, and I already have BuRi-P4. So I'm interested in it as a broad spectrum epithelial marker. So my reading of the literature is that it's expressed in everything carcinoma, but it's negative in mesothelioma.
Yes.
Is that how you're deploying it?
Yes, especially with when I have cell block of pleural effusions or peritoneal, because I don't want to have the overlapping with the keratin, the
Yeah.
mesothelial and epithelial. So Claudin 4 is a good marker because it's negative in the mesothelial
How do you
cells.
like it compared to, do you use Mach 31 or BERT EP4 for that application?
Sometimes I also use Mocteri EPCAN, but sometimes EPCAN can have that blushing in that mesothelial cells. So I use both.
Yeah, and this is another good example of added value of semi-quantitative IHC stain assessment. I could pull up another slide of, you can certainly get EpCAM positivity in a mesothelioma. It's qualitatively very different than the EpCAM positivity you'd get in a carcinoma. You might get a little wispy here and there membranous staining, which is not like the EpCAM positivity that you would get in an adenocarcinoma. I'm glad to hear about your experience with Claudin 4. I've got the fellow who's on GI next month that's teed up to bring up. I do a lot of mentorship in IHC lab directorship, and what I do is when the fellows rotate on GI, we try to bring up 1 or 2 new immunohistochemical markers. All right, let me share the screen. Can you see the PowerPoint slide?
Yes.
All right. I'm not going to try to full screen it. So this is an example study. There are several studies that look very similar. This is specifically Lisa Rupert. She's a head and neck pathologist at Hopkins. And she did a couple really nice INSM1 studies. And this one was in lung. She did a similar one in head and neck, and there's other studies by other authors. But the study very well reflects the central mass of the literature. And what I found in my study, I'm not sure if I have I hope I have my study in here. So INSM1, hands down, is more sensitive in poorly differentiated neuroendocrine carcinoma. So small cell, large cell. And so they found 95% sensitive in small cell and 91% sensitive in large cell. And that compared very favorably with synaptophysin 6261, chromogranin 4948, CD56, which is actually stain I hate. I don't use it as a general neuroendocrine marker. And not only did INSM1 beat chromo and synapto and CD56 combined, 95% sensitive, 91% small cell, large cell. And then compared to combined, 74% and 78%. It's not just sensitivity, it's confidence. The higher the H score, right? The product of the intensity and the extent. And this is that added value of semi-quantitative stain assessment again. The higher the H score, the more the confidence. So not only is INSM1 more sensitive in small cell and large cell, the H scores are higher. So they got H scores of 150 and 100, and that blew the doors out on chromogranin and synaptophysin. So I actually was the peer reviewer for the first INSM1 study that was submitted to AMJ ClinPath, because I've been on the editorial board for that journal for 15 years. And I was like, oh, great, this is neat. This is like a nice general neuroendocrine marker. And I did not bring the marker up because chromogranin and synaptophysin are fine. But I blew it. I should have investigated it because INSM1 has no added value in well-differentiated neuroendocrine tumor. It's this poorly differentiated neuroendocrine carcinoma application where it's clear first choice. Here's the data from my study. Very similar, 97% sensitive in small cell. I thresholded based on site of origin. 95% sensitive in Merkel cell, and again compared favorably with chromo and synapto, and again really big H scores. One sort of last quick thing to mention is with any general neuroendocrine marker, and INSM1 is no exception, you will frequently have some general neuroendocrine marker expression in a non-neuroendocrine carcinoma, especially in adenocarcinoma, but also in squamous cell carcinoma. And I don't even start thinking about specificity for neuroendocrine carcinoma until at least 30% of the cells label. So if you have 1% cells staining or 5% cells or 20% cells, I refer to that as occult neuroendocrine differentiation. And that's a huge pet peeve and a frequent source of diagnostic confusion, where we get all these diagnoses of poorly differentiated carcinoma with neuroendocrine differentiation, and the clinicians say, is it small cell or not? And INSM1 is no exception. So so the brain met that they showed me right before I got on the line with you, they've been listening to me for long enough. They said, the INSM1 is positive, but is it positive enough? And I said, no. It was 1 plus 10 or 20%. I said, no, this is occult neuroendocrine differentiation. This is a metastatic lung cancer. Awesome. Nice to meet you, Anna.
Thank you.
Hope
Nice to
to
meet
meet you in person someday.
Yes.
Thank you.
Thank you very much, and thanks for agreeing to stick around if folks have other questions. That last quick point was the one that I wanted to ask, so there was a lot of prescience there. I appreciate that. Next up is in our agenda is the presentation from the next of our gold sponsors, so for Alexion, and we look forward to that.
Thank you, Dr. Tallman.
Any questions for her? Again, as a reminder, the virtual exhibit booth is open with the chat function there, and contact information if there's anything that you wish to ask offline.
Okay, well, thank you very much. And Carmen, I'll send you the program invite and ask you if you could share that with your members, and if and my contact information as well. Okay, thanks so much. Have a great evening.
Suzanne.
Thank you. All right. Without further ado, and then we can probably maybe move through some of this fairly quickly, is the NAP business meeting. We do have some business to conduct regarding elections. So I think because that's the thing that the bylaws say we have to get done at this meeting, I like the order of the agenda here. Let's do that first. So I'm going to officially call the NAP business meeting to order. And beginning with the elections, just to let you know, the process for this per our bylaws is that we assemble a slate of candidates put forward by the nomination committee, and I nominated the executive committee to serve that function just basically out of ease for logistical purposes this year. And so we do have a slate of folks to put forward. I don't know, Carmen, do you have that ready to go for everybody?
Yes, I do. Just a couple of things. Some of the people who either nominated themselves or were nominated included several positions. So in between each poll, we'll use the polling function. I'll go in and remove whoever was elected from the subsequent polls. So just be patient with me as we go through this. And if you have any questions, if you've never used the polling function, it's pretty easy. It just pops up on your screen and you choose the person that you'd like to elect. Keep in mind that once we get to the members at large, we are choosing 3 people out of the entire slate. And I think that's all that I have.
Perfect.
So these were the candidates. We had, I believe, at least 10 days to turn in the names. So I appreciate everyone who filled out the form. As you can see, the ones with the star and kind of italicized are on there several times. So if we're ready to go, does anyone have a question before we get started? Okay.
What are we voting for first?
We will actually be voting for president-elect first, just because of how the candidates came out. So it'll be labeled poll number 3, but it's actually poll number 1. So I will share that with you now. And we'll give, I don't know, I think maybe 20 seconds is enough time between each poll. And just so you know, for any time that we have just one candidate, we still have to go through this. So if you're wondering why we're still choosing just one candidate, it's in our bylaws that we still have to take a verbal vote, but we're not in person. So this was the next easiest thing. Okay, and I'm not seeing any other voting happening, so I'm going to end the poll. So Dr. Swanson, congratulations. You are our new president-elect.
Excellent.
Thank you.
Okay.
So just to share, I believe that means you are president-elect for the next 2-year term. Gene Thompson will be stepping in as my immediate replacement as the incoming president. So that's kind of the way that this works. So you are been on the hook now for 4 years. So congratulations and condolences.
And just so you know, your terms do start at the end of this meeting.
All right. Next up, Secretary Treasurer. So that means our slate has been reduced to 2 folks.
Mm-hmm.
And this is a vote for 1, correct?
Yes, this is just a vote for 1. Okay, going once, going twice. All right, so Dr. Boebert, congratulations. You are our next secretary and treasurer.
Thank you.
Congratulations, Dr. Boebert.
Thanks.
And with that, just give me a sec and I will edit our last poll. All right, so this again is for members at large. You can choose up to 3 candidates. Okay, 5 more seconds. All right, so we have Dr. Lintel, Dr. Tegmeyer, and Dr. Ewell Valdez.
Thank you.
Excellent. Congratulations to everybody. I want to thank all of you folks for your interest. This is probably one of the most robust slates of candidates that we've had for NAP officers that I can remember in my pseudo short tenure with the organization. And for those of you that didn't, that maybe didn't get the office that you want or weren't elected, don't worry, because I'm sure there are lots of initiatives coming down the pike and plenty of opportunity to continue to be involved. So don't worry, you're not going anywhere.
Yes, thank you to everyone who participated, and especially thank you to the current board. You guys have been extremely helpful as I started out this position at the end of 2019, and we transitioned to COVID together. So it's been a pleasure to work with you.
The feeling is most definitely mutual, Carmen. We thank you for everything you've done for us.
Thank you.
All right, so Carmen, I guess you're still on. If you want to go through the next administrative updates, which include membership and financial information for the group to see.
Yes. So membership right now is currently at 83 members. Decreasing membership is one of the things that I'm hoping that we can continue to tackle this year. As you know, aside from people retiring or residents leaving the state, we've just been having a steady decrease for the past, I think we made our comparisons in 2017, so at least 5 years of decrease. And so, you know, we are hoping to be able to continue ramping that up and, you know, providing notices for people who didn't sign up this year, and just doing all the things that we were doing this previous year in terms of communication and trying to keep everyone in the state as members. And then with regards to the financial update, you can see our finances up on the screen. Our balance currently is, or through the end of March, is $11,726. You can see on the profit and loss side just what we have spent and gained this year. So I'd be happy to answer any questions regarding the finances. There's not a lot of activity in terms of movement of funds. So, you know, I'd be happy to answer any questions you have of where we stand financially.
So whilst people are going through, maybe thinking of questions or looking at these numbers in a little more detail, I will share some information that Carmen was able to pull together for me regarding membership. The last year saw a delta of -7 members when you put it all together, -8 members when you put it all together. We gained 15 new members. I think those are mostly trainees, I'm going to guess. I'm not sure about that, but we did lose 23. Of the 23, 3 moved out of state, which, what are you going to do? There's not much you can do about that. 10 of them were folks that were probably retired, based on our information, retired. So about half of the 23 we lost makes sense. I think in looking at the folks that fell off, that just the names of the folks, which I'm not sharing just because I don't think this is a good forum to do that. But many of them are young pathologists, people who maybe were members and are not anymore. So I think that probably what this speaks to is 2 things. One is our organization is sort of shrinking by means of just general attrition. The average age of pathologists in Nebraska I think is been fairly high for a while, and so we're experiencing some of that. But I think we have a lot of potential opportunity to capitalize on the new people that are coming into groups to replace those people who are retiring. And I think that's an area of focus that we can probably consider discussing. And I think the data that Carmen you pulled together is very, very helpful, because I think exec is going to take that most likely and work with that. So, On the finances, just to let everybody know, Gazette goes over this a lot, but you may not be privy to that. The sponsorship of meetings has helped us a lot in terms of our bottom line. We are in a much better position this year than we were last year and the year before, basically because of that. Our major expense this year is very well spent. That is the administrative services that the NMA provides, and they do an incredible job. That's our major expense, especially this last year without physical meetings. So. Any questions, thoughts, or concerns from the group? This is, again, more just informational.
Okay.
Okay.
If you have other questions that you'd rather email me about, that's definitely acceptable. That's what I'm here for. So moving on to the NMA update, just legislatively, it's been a good year, which was surprising to us because, you know, with COVID, there was a lot of uncertainty about how much we would be even able to get done. As you guys know, the legislature decided to still meet in person anyway, and went through legislation beyond just the budget, which is something that legally they're bound to do anyway. So just a couple of legislative wins or good news. There was one bill that would have affected the entire House of Medicine. Senator, I don't remember, but it was LB 133, and they wanted to basically change the tax structure of the state to include taxing services, and that would have been all sorts of services, haircuts, etc. But that would have included medical services. So in addition to, you know, whatever bill you might get from a clinic or a hospital or a practice, it would have harmed patient care at that point, making healthcare less accessible. Another one that has been just put on hold. It did not get out of committee, nor did it get a lot of support, was Senator Wayne's bill. Senator Wayne from Omaha introduced a bill that would have increased your liability caps tenfold, and so making it extremely expensive to be a practicing physician, because that money comes from somewhere. It doesn't just magically appear. And so that one has not moved. He tried that at the end of the last session, and he's a trial attorney. I'll just kind of be frank about that. So we kind of question his motivations, you know, when he's trying to push that. And there doesn't seem to be a lot of support from the committee, but we'll keep an eye on it. Technically, it's kind of dead in the water for this year, but because so our legislation works. Each session is 2 years, so you have a long session, which is this year, and then you have a short session, which is next year. And whatever was left over from this year will roll over until the next year. So his legislation is still active, but it's just not really moving. There was also a COVID liability bill that was supported, but the Nebraska Supreme Court kind of gave recommendations that they couldn't apply the liability protection for businesses, physicians, or anyone retroactively, which, you know, until it gets signed by the governor, everything would just be moving forward. And then at that point, there's kind of a question at the committee level whether it's worth pursuing if it's not going to cover your, you know, protect you from liability during the worst of COVID. And so that's just kind of a few of the big wins that we've had this year. And so we've had a few others that don't particularly affect pathology, but those are the ones that we were keeping an eye out for you guys. Then with regards to the annual meeting, if you guys are NMA members, that's coming up September 17th. And that one will be held at the Embassy Suites in La Vista this year. And then the other thing I wanted to bring up is our LifeBridge program, which is it's a free peer-to-peer kind of counseling, but we call it coaching, a program that we have available. It's completely confidential. We don't process anything through insurance. There's no diagnosis. And it's basically a mental health support. It's all volunteer coaching, and it's made by physicians for physicians. And so just encouraging, if you or anyone you know you think might need these kinds of services, just definitely recommend that you reach out to LifeBridge.
Thanks, Carmen. Just again, underscoring the value of our involvement in organized medicine, the NMA and the NAP specifically with our partnership. For those of us that don't pay attention to a lot of this stuff through other methods, those bills that were coming forward were potentially like earth-shattering. I mean, those were paradigm-shifting bills, and so again, this is why it's important for us to be involved and be knowledgeable, and why the communication the organization is doing to the membership is absolutely critical. I also want to put a plug in for that LifeBridge thing. A lot of people think that pathologists are immune from burnout because, gosh, you're a pathologist, you only work 8 to 5. What's your thing? There are data from both the ASCP and the CAP showing that while we do have the lowest percentage of burnout amongst specialties, it's still 33%. So if you think about what that means 1 of 3 of us, 1 out of every 3 pathologists experiences some degree of burnout or lack of wellness related to their profession, which I think even one it's a problem. So be aware. It's important for us to be aware of this stuff and to watch for the signs of this of this mindset in our colleagues, and don't hesitate to intervene. Okay, CAP update. Jean and Scott, I think you're here too. Anything? I don't mean to put you on the spot here, but anything to share from the House of Delegates? I think Scott was here.
The House of Delegates meets next week with the physician leader or the pathologist leadership summit, which I was going to talk about. It's free to register. It's all online. It has some good educational courses as well as some stuff that touches on advocacy that we can use at a state level as well at the national level. The only other update I've seen with the CAP, since we haven't had a meeting since the last NAP meeting, one of the big advocacy wins we've had is that Congress has decided to delay the 2% Medicare cut until the end of 2021. And that was a byproduct of the CAP working hand in hand with the AMA. So just kind of shows our work with the CAP really kind of helps us here on a local level.
They continue to kick that can down the road, it seems. Thanks, Tyler. I didn't see your box, so thank you for giving us that update. All right, last update on the fall meeting. Carmen, you want to summarize the exec's conversation, what we had regarding that?
So our hope for the fall meeting is an in-person meeting. A lot of this, you guys might know, I manage 13 different specialty societies, so a lot of them are moving forward with an in-person meeting. So our hope is really to be able to do that. And we'd again do it in Omaha, and we're trying to create a virtual option for people outside of the Omaha area. We're hoping that people in Lincoln will be willing to travel to see their colleagues in person, and then still be able to connect with everyone from across the state without having to travel 8 hours to get to Omaha. So just some of the things that we discussed, we're exploring different venues to try to host our meeting aside from just a conference hall type venue. And then trying to see if there's anything else I forgot, Dr. Talon. Oh, and we'd be hosting resident presentations this time. So we do, like we did our last fall meeting, one from Creighton and one from UNMC to have as speakers.
And that's been a longstanding tradition of the NAP, and I think that's very, very important. It shows that it shows our support of the next generation of pathologists. Dr. Bober had an idea that he shared with me too that I think exec is going to explore more in depth about even following that, perhaps either in lieu of or truncating the business meeting to some degree, that we actually have a panel conversation for residents, that we have a lot of folks from a lot of different practice environments, and this will give them an opportunity to just ask questions about what daily life is for those of us that don't practice at one of the academic institutions. So we've got it's promising to be a very robust, exciting meeting, and I hope to see everybody there. More details to come, most definitely. With that, we've just a little bit over. I want to thank all of you. This is my last meeting as president, obviously. Dr. Thompson takes over for me. I assume the best office in any organization at this point, which is past president, which allows me to participate but not have to do anything. So I'm very, very, very excited about that. I want to thank everybody for the trust that you've placed in me, keeping the NAP going and helping this incredible group of folks, all of you, forward, especially through COVID and everything else, and I look forward to what's to come. So with that, we will adjourn. Anything else for the good of the order before we all leave?
Great job, Jeff.
Good job.
Yes, thank you.
Thanks for your service, Jeff.
Thank you.
Great job.
All right. Well, thanks, folks, and I'll see you all probably sporadically before fall, and hopefully, cross our fingers, we will see each other face to face in the fall with a glass of wine. So,
Amen.
Good night, everybody.
Thanks, everyone. Goodbye.
Good night.
Thank you, everyone, for attending.